So I'm here to introduce our next speaker. Ko tēnei wahine Aotearoa, ko Lizzy Kepa-Henry. Lizzy is a public health nurse at work and income-based role is supported by regional public health, and she contracts with Ministry of Social Development. Lizzy also provides on-the-spot interventions as a conduit service linking and supporting Ministry of Social Development and income clients to connect with much needed health services. This work is a privileged role that allows Lizzy to navigate at Flaxroots and resolves vulnerable and diverse clients' unmet health needs in collaboration with work and income case managers. Lizzy is also a palliative care and oncology nurse, maintaining her clinical practice through Healthcare Duty Calls New Zealand Nursing Bureau. Lizzy is passionate about collaboration and services that navigate a way forward to improve Māori health outcomes. Lizzy also plays a important role as her lead role for Te Poari, Te Runanga Aotearoa. She is the Kai Arahi, the representative for Te Upoko o Te Ika a Maui. So, I'd just like to introduce Lizzy to come in and speak to you all. So, kia ora tātou.
Hi. Kia ora tātou. Tēnā tātou katoa ngā tuakana teina nehi, kaimahi hauora, ngā mema tōpu tangata apuhi kaitiaki o Aotearoa. In admiration, I greet you all, my respective nursing and health professional colleagues, NZNO. To those before me, to those whom I've trained and worked alongside, and to you, our future nurse workforce. I pay homage to our brother and sisterhood nurses throughout the world who pre-COVID, during and post, gave of themselves that our vulnerable and diverse communities may be well. Please join with me but for a moment in honour of our health warriors who lost their lives from COVID. Ko tarawera tōku maunga. Ko te awa o te atua, tōku awa. Ko tarawera ko te arawa tōku waka, ko rangi aohe tōku whare tipuna. Ko rangi tihi tōku marae. Ko Lizzy Kepa-Henry tōku ingoa. Organically cultivated into Māori realism, the heart of whānau Wellbeing was a self-governing, interwoven foundation of marae-based communal living. This allowed my whānau to upkeep traditional practices of importance, to retain cultural memories, identity and prestige, our cultural autonomy to plan, pursue, participate in, evaluate our own choices, shaping the conditions under which I've been brought up in. An approach based on social and community responsibilities that link to the wider whānau, hapu and iwi. A means to openly conduct routine decision-making processes that accomplished holistic whānau equilibrium and admirable standards of living. Colonisation witnessed a decline in this commendable style of living, ill-positioning my parents' vulnerable decision, joining the issue of the urban drift. I've entitled my presentation, Cultivating Community Wellbeing at the Flaxroots of Vulnerable and Diverse Communities. I'd like to give you a national glimpse. I am one of 3 RNs based in the biggest work and income sites in New Zealand. Manukau is the biggest, Rotorua is the second biggest. Both these roles provide a nurse-led convenient clinic providing free healthcare services. The third biggest is Porirua, where I am the only public health nurse working income based in the country, providing a conduit service linking vulnerable and diverse working income clients to services to address their unmet health needs. The key stakeholders to the service is delivered through a Memorandum of Understanding contract between the Regional Public Health, Hutt Valley DHB, and Cape Coast, 20 hours a week based in the Porirua Work and Income site. A contract for services with the Ministry of Social Development provides a further 20 hours a week within the NZNO Work and Income office, though only a quarter of the size of Porirua is the biggest site in the Hutt Valley, with the highest volume of young consumers. Key to this service is building reciprocal connector relationships, embodying communication with Ministry of Social Development staff, health professionals and community and the like. I now present to you the National Ministry of Social Development statistics. This is a quick overview of the main benefit recipient figures. By the end of July 2020, there were 355,648 main benefit recipients. And by August 2020, this number increased to 361,000 plus. The supplementary benefits that work and income clients can access are known as TAS, DA and AS. The TAS benefit is a temporary additional support, which is a weekly payment that helps to cover essential living costs that cannot be met from their income, benefit or other resources. TAS is paid for a maximum of 30 weeks. The figures shown here are the main benefit recipients. And in August 2019, there were 68,000 plus, compared to the July 2020 increase of 31.9%, showing an upsurge total figure for July 2020 to 90,000. Proliferating this additional 3.3% increase, which intensifies the August number to 93,335. For the disability allowance, which is a work and income tested benefit, if you're eligible, a main benefit recipient can receive up to $64 extra a week. In August 2019, there was 231,492. By July 20, we see a slight increase to 234,000 plus, and for the August figure, 235,040. The accommodation supplement is a weekly benefit to assist people who are not in public housing with their rent, their board or their mortgage. In August 2019, there were 305,682. This number increased to 355,000 plus by the end of July 2020, further increasing this number to 361,652. The COVID-19 Income Relief Payment, otherwise known as SERP. From the 8th of June 2020, people who lost their job between 1 March and 30 October can apply for this benefit for up to 12 weeks. The numbers reported are of those eligible aged 16 and older. The national figure by the end of July was 20,957. And by the end of August, this had increased to 24,811. For the Greater Wellington region, end of July was 10,925, decreasing this figure down to 7,149. And this decrease is attributed to the recipients at the end of their 12 weeks, and most transitioning into a work and income benefit. The housing support in the Greater Wellington region. In the first yearly quarter ending March 2020, for the total TAS or temporary additional support payouts was 433,814. As you can see, there's a 15% increase by the end of June to 499,000. For the accommodation supplement, in the first yearly quarter ending March 2020, the total accommodation supplementary payouts was $2,675,268. This total increased by 7%, paying out a further $187,641. So by the second of the year of the quarter ending June 2020 was $2,862,905. $909, sorry. And in terms of the 3 DHBs, for the Wairarapa, there were 778 clients. Hutt Valley had 1,142, and CCDHB had 1,892 clients accessing the emergency housing and special needs grants, which helps individuals and families with the cost of staying in short-term accommodation, like motels. In the first yearly quarter, for the Wairarapa DHB, $1,334,755. For Hutt Valley, $3,094,671. And for CCDHB, $4,514,48. The total amount by the end of the first yearly quarter, March 2020, there were 2,948 for the Greater Wellington region, clients who accessed this emergency housing and special needs grants. And by the end of June, there were 3,812. The dollar figure, spend, payouts for the accommodation supplement by the end of March was $5,504,741. And by June 2020, $8 million, almost $9 million. I think our DHB needs some more money so that this PowerPoint will move a little bit quicker. Making a difference. As an on-site public health nurse, you may believe that you understand what a public health nurse is. Let me provide you insight to my job. That your takeaway pack today is acknowledging that we are colleagues. Our professional relationship matters equally, as does our responsibility to treat and care for people with respect. A public health nurse referral process is available for any work and income client needing help. This is filled and uploaded into Concerto. Referrals are predominantly work and income case managers, but note, there is an MSD process to follow when engaging with the work and income case managers, which can have a long turnaround, often between 2 to 6 weeks before a client can be seen. Health expertise and advice is provided to clients. For complex medical conditions or urgent attention, extra cases are put to case managers via my role over and above their already busy caseloads. I discuss with you today 4 work and income health disparities that give rise to how these social determinants impact the health, wellbeing, and employment status of consumer users of the service I provide. In 2016, the International Monetary Fund found New Zealand has the highest house price to income ratio in the world. Making matters worse, New Zealand housing are also not even great quality. An Otago researcher found up to 10% were unfit for living. It was so bad that the UN officials had to declare it a threat to human rights because of overcrowding, increased family violence, and flared inequality by disproportionately affecting Māori, Pacific, and low-income earners. In the Treasury's Budget Economic and Fiscal Update, Ministry of Social Development Benefit Forecast Summary released in May 2020 highlighted that in February 2020, around 300,000 were receiving benefits. In January 2021, MSD expect working age benefits to peak at around 490,000. That's around 155,000 more people that will be on benefits. This is largely driven by the job seeker support with a flow on supplementary assistance payments such as the accommodation supplement and the special needs grants for emergency housing. Meet somebody. Somebody suffered a stroke. Somebody had a discharge plan for GP input, 38 hours care coordination package for 1 week, per week, sorry. Somebody was obese, mobilised via wheelchair, had 42 staples in situ and a smorgasbord of medications. There was no OT, social work or physio input on the discharge plan. Somebody in her whānau lived in an uphill 2-storey home. There were 15 steps to the front door and the back door entrance had 23 steps. With 21 steps to climb, somebody had a total of 36 steps to her hospital bed in the lounge on the 2nd floor. There was no wheelchair access to the toilet, the shower, and she had no hoist. The whānau reported that carer input was for less than an hour a day. Somebody's housing New Zealand rental of $110 increased the private rental because of her medical condition to $540 a week. Access to housing. Access to health services. Meet anybody. Anybody is very aware of his mental health condition. Anybody rang for help from the emergency mental health service. Access to help would be at least 2 days, awaiting a follow-up phone call and an appointment. 2 days later, anybody's phone broke, so he possibly missed the call. On day 4, anybody contacts the emergency mental health service. Anybody is informed that he had missed the phone appointment. Anybody's mood further elevates in anger and he responds, "What does it take for a man to get help? Do I have to come down there with a shotgun?" Following anybody's arrest, he's released on e-bail and he's referred for public health nurse support for intervention due to being trespassed from the emergency medical health centre. We have a connection with a GP and anybody is prescribed medications which is dispensed twice daily from a pharmacist. Anybody doesn't have a car and the cost for him for his daily medication twice is $32 a day. Access to health services. Access to transport. Meet who cares. I had received a child, youth and family in that time, we're now Oranga Tamariki, for a baby who'd been hospitalised twice for bronchiolitis. I met who cares mobilising down the stairs and I said to him, "What's the matter with you?" He said, "I just got out of hospital," and walks past me into the lounge. He picks up a piece of paper and it's a week-old prescription charted for 120 mgs of Clexane, daily bloods and warfarin. Who cares was left with $65 a week after his rent was paid, but his medications cost $85. There was he had no car, there was no bus route where he lived, and it was in the middle of winter. Stroke, as you know, would leave who cares severely debilitated, or he would die. I rang his medical service questioning why there was no follow-up and why they weren't receiving his blood results. Unfortunately, Who Cares did have a third stroke and he is severely debilitated with 24/7 care from his mum who had to finish her business. Access to transport. Access to education. Meet nobody. Nobody presented to my desk looking like this. Nobody really wanted to work but kept failing the job medicals. Nobody couldn't remember when he had last seen his last GP or who it was. So I called the Ministry of Health to identify who his last GP was. It was a decade ago. It just so happened that the GP service I'd engaged with was the very service where nobody previously tried to enrol. Nobody said they gave him papers, but he handed them back empty. also failing his GP enrolment process. I was able to get nobody in finally to see the practice nurse. There was no introduction. Nobody was really nervous. The nurse took his temperature, it was 37.3. His blood pressure was 168 on 92. His blood sugar levels were 17.3. And the only time my colleague responded to both of us was when I asked what the results were. I informed the nurse of nobody's previous attempt to enrol with the service. I said he'd been handed a paper to fill, and he hands back this paper empty, not once, but twice. The nurse's first time response to nobody is this: "So you can't read or write." Nobody did see a doctor a few hours later that day. Nobody not only had chronic facial abscesses, but he had multiple abscesses on his upper body. Access to education. Today I'm speaking as an advocate. When I was asked to present as a public health nurse working at the Flaxroots of communities, I received this as an opportunity not to be missed. You see, people who cultivate the land often become its owner. But in my public health role, my clients, your patients, often struggle with cultivating their standing place because for many, they don't have one. It is either rented or short-term, and for many, they long for a forever home. Many of them don't recognise themselves as being vulnerable or diverse, but just living and surviving day to day. This is their normal. I ask that you understand that I am only one person servicing 2 work and income sites and often addressing regional. You are my colleagues and I long for a professional relationship with you all. But no matter what, relationships are equally as important as responsibility, and that is to treat and care for people with respect. It has been an honour and a privilege to piece together these important pieces of work, because I've come to realise through this process that my role is actually invisible. We are all important in responding to our clients, our patients. Now that you have understanding of my work, I leave you with this whakatauki. He waka eke noa. We are all in this together. Nō reira, tēnā tātou katoa.
Anō reira. Tēnā koe, Lizzy, mō tō kōrero mai ki a mātou, o kōrero tika, o kōrero o whakaaro pai hoki ki a mātou. So, so I just want to say thank you for your kōrero today to us nurses, and I just want to say, to my nursing colleagues out there in the community like yourself, I know it's not an easy job because, you guys out there are the doctors, you're the physios, social workers, occupational therapists, dietitians, everything. So for the life of me, I'm going to say this, I don't even, I can't understand why we in the DHB get more than you guys. So I'll leave it there. So, because I am a nurse, you are a nurse, Lizzy. So thank you so much. Well, I don't think we have any questions. So that tells me they're happy with what you do, Lizzy. So I just want to... Oh, one question.
One question.
Where is it? Oh, taihua. Oh.
There we go.
Anyway, okay, so I'll just read this question out. This is from Margaret Hand from the Tai Tokero. And kia ora, Lizzy, thank you so much. Should we have nurses in all wins throughout New Zealand?
If that's a direct question to me, the answer is always going to be yes. Like I said, there are 3 nurses, but I'm the only one providing this type of service. The other one, as you know, is in Manukau and Aotearoa. I'm hoping that the MSD, through the reports that have gone in, will look at rolling out nurses in all the work and income sites. But, that's a space to be watched for. Kia ora.
Oh, kia ora, Lizzy. So, I think that's it for this afternoon. So, wonderful job there, Lizzy. Thank you very much. Keep up the good work out there, our nursing colleague, and
Thank you.
everyone else out there. So, anō reira, tēnā koe kei te tuakana. Nā mihi.
Ngā mihi.